So we have the much awaited talk of our eminent speaker, Dr. none other than Dr. Namrata Sharma from RP Center. So she'll be talking to us about a paradigm shift in the management of dry eye. Because so many drugs are coming up, and we all know that there is some ocular residence time, ocular surface residence time, because 70% of all the drops is lost due to blinking or some other reason, and all the companies are trying out to increase the residence time. So different techniques are into use, like
Thank you.
increasing the strength of the drops and all.
Thank
Over
you,
to you, ma'am.
Thank you, Anita. And it's always a pleasure to come to Kerala. And always I say this whenever I'm on a platform in Kerala. And the best scene to see is, so many female ophthalmologists, almost 95%, with due regards to all the men here. But that's the pleasure to see, which I don't see in any state. So lovely to be here again. And I'm so happy that all of us are now taking ophthalmology. At our times, only 5% were ophthalmologists, females, and 95% were male ophthalmologists. But it's lovely to see here. So I would be talking to you about paradigm shift in management of inflammatory dry eye disease. And it is a multifactorial disease. I think you must have, this must have been already covered, but it is a multifactorial disease because it's not a single symptom, it's not a single sign. It is something which was recognized from 2007. Earlier it just was passed off as dry eye. Then it is something which actually encompasses the entire spectrum, right from eyelids, lashes, tear film, main and accessory lacrimal glands, and the meibomian glands. And there is loss of homeostasis, which goes through the central pathophysiological concept, again something which was not known. Symptoms are very important because they never corroborate with the signs that are there, and there can be many etiologies which we really need to know. And of course, I think the most important thing is that you need to know when you are treating a patient of dry eyes whether the inflammatory component is there or not. Now, this is a busy slide which just goes on to say that this is a vicious cycle of inflammation, dry eye disease, and MGD. And when it is a vicious cycle, you have to break it somewhere, be it steroids, it doesn't matter, or be it immunosuppressants. So when you break it at a particular point, with the use of topical steroids or immunosuppressants, then you can continue with lubricants. Lubricants are something which the patient, you can never take them off once you start the patient on dry eye. Of course, investigations, I think Madhu very nicely covered the investigations. And there are various signs which need to be treated, like conjunctival hyperemia, conjunctival staining, because with the lissamine green, which will tell you the extent of inflammation. Then the lid parallel conjunctival folds. Confocal microscopy may not be available everywhere. Tear osmolarity, I think, is important, but I think it is more an effect rather than the cause of the dry eye. And I also feel, I did go through the first half, but I feel that it is slightly overrated. But then, of course, if it becomes normal, then it helps you to know that, your treatment is working. MMP9, which again is not very specific because it has to go really high to be detected and to be saying that there's some inflammation which is present. So there are triaging questions, the risk factor analysis, the diagnostic tests, and the subtype classification, because based on the classification you are going to treat. So if it is a mild dry eye, it is only patient education, modification of the local environment, and ocular lubricants. Like I told you, and initially I would start ocular lubricants 4 times a day, which would be something like a CMC. Then step 2, if it is more than 4 times a day, we start with non-preservative lubricants. Demodex will be treated with tea tree oil. Tear conservation is very important with punctal occlusion if required. And of course, the drugs have to be prescribed. And if there is inflammation, then topical steroids can be given 4 times a day in frequency. I don't like to give, although this is a Sun Pharma session, but I don't like to give Lotepred or FML for that matter. If I have to give steroids, I'll give a full-on steroids because we want to break that vicious cycle. So it will be something like prednisolone acetate, which will be 4 times a day. Then topical non-steroidal immunomodulators, cyclosporin has a role to play. Liftigrast is undergoing trials, is available as Xiidra in US, but is still not available with us, and oral macrolide or tetracycline wherever indicated. Now, if it is very severe and the patient is really uncomfortable, you can give oral secretagogues, which could be pilocarpine, which is given 3 times a day. But again, the systemic side effects are quite a bit. Then autologous or allogenic serum eye drops can be given, and these are helpful, 20% in concentration. And of course, if the above options are inadequate, then you have to give topical steroids for longer duration, amniotic membrane transplants, tarsorrhaphy, and even minor salivary gland transplantation. Now, what are the challenges? We have definite ground why immunomodulators should be started, but there are certain challenges which are there, and these include the following. Now, there have been studies in more than 7,000 patients which had patients of topical cyclosporin also, and majority of the patients actually discontinued topical cyclosporin, close to 60%, close to 70%, and close to 60% discontinued liftigrast. So discontinuation does occur in these patients, and this occurs mainly because of burning and stinging and lag time which is there between the treatment initiation and experiencing the symptomatic relief. So this may lead to disease progression, especially when the patient discontinues, and so you do require a maintenance therapy. Now currently we have liftigrast, but the liftigrast also causes other side effects like dysgeusia and reduced visual acuity or blurring in some of the cases, apart from eye discharge, eye discomfort, hyperemia, sinusitis, etc. Topical cyclosporin 0.05%, which is currently available, does cause ocular burning in almost 17% of the cases, apart from conjunctival hyperemia, discharge, pain, foreign body sensation, stinging, etc. And the effect of the topical cyclosporin 0.05%, which is currently available, starts within 6 weeks. So the unmet need is that the currently available cyclosporin is actually available to you in oil and aqueous solution, and the solution with the drug particles do get suspended in oil particles, but it tends to be unstable with poor ocular tolerability, hampers the dissolution and penetration into aqueous tissue, and it must be shaken to resuspend the drug particles. Again, it will cause blurred vision and low bioavailability in ocular tissues, which will impact on the onset of action, which I said was 6 weeks. Now, cyclosporin 0.09% is the ophthalmic solution, which is made by the nano micellar cell technology, which basically has a hydrophobic shell. So this allows transport through the tear film onto the ocular surface and has a hydrophobic core, which prevents the encapsulated cyclosporin from being released until after the penetration into the aqueous layer. So because of this, the penetration is also faster and it acts faster. Now, again, this is to show the same, that this N cell encapsulates and this hydrophilic shell which is there, it gets dissolved. So with the N cell technology, the cyclosporin penetrates inside and then it gets delivered onto the ocular surface as well as intraocularly. Now, this was a study which was done in animal eyes, the New Zealand rabbit eyes, and just to show that if you look at the concentration of 0.05% Restasis versus 0.05% micellar cyclosporin and versus 0.1% micellar cyclosporin, then you can see that the 0.1% micellar cyclosporin in conjunctiva and cornea has higher concentration, and again in all the tissues in fact has higher concentration. So it has gone through 3 phases, phase 2B, 3 clinical trials, phase 3 clinical trials, and the long-term safety extension study. And if we look at it, this was the phase 2B, phase 3 study, which looked at nanomicellar cyclosporin, which came by the term of OTX 101, 0.09%, vis-a-vis vehicle, vis-a-vis 0.05%, because they wanted to look at which concentration is better, 0.05% or 0.09%, and the treatment duration was 12 weeks. And it was found that the one which had nanomicellar cyclosporin 0.09% had faster action, which was 2 weeks as opposed to the vehicle. So that is why it is more efficacious as compared to 0.05% nanomicellar as well as 0.05% which is commercially available. Now this was another study which was again randomized controlled trial in more than 700 patients, which looked at the one which was proven, that means nanomicellar 0.09%, vis-a-vis vehicle to look at the safety, and this was again done for 12 weeks, and at all points in time it was found that the nanomicellar cyclosporin had improved the total corneal staining much more as compared to the vehicle. And I think corneal staining is very important because corneal staining means that the patient is having symptoms and is also having signs. Then this was again for the global symptom score or what we called as SANDE. That is how we analyze the symptoms of the patient. And again, both the treatment groups, they demonstrated 30% mean decrease from baseline in modified SANDE scores, and there was no difference in the treatment effect which was observed. And of course, artificial tears were not allowed in this study. Now again in visual acuity, again the same data, it was found that the nanomicellar cyclosporin patients did better, and there was also at 3 months 65% of the central corneas were completely clear with 56.9% in cases of nanomicellar versus 38.3% otherwise, and the same results were also replicated at 3 months follow-up. Now, this is the real world treatment in patients with dry eye disease. How did they arrive at it? They went to all the insurance companies. In India, this treatment is not covered by insurance, or these drugs may not be covered. But this was a study which was in US where drugs are covered by insurance. And they wanted to know how many patients were on cyclosporin 0.9, 0.05 or liftigrest. What was the discontinuation time to treatment and discontinuation of these? And it was again found that the patients who were in the group of nanomicellar cyclosporin, the mean treatment duration was 11.6 months vis-a-vis 8 months for liftigrast, vis-a-vis almost 7.9 months for the commercially available cyclosporin. So the discontinuation rate with the nanomicellar cyclosporin is also less. Now, this again looked at the instillation site pain to stop the dry eye disease, and more than 95% of the patients experienced either no or mild instillation of the site pain with the nanomicellar cyclosporin, which is actually being marketed as Sequa from the Sun Pharma Pharmaceuticals. This was for the safety, whether there were any ocular adverse events or not. And again, the issues were only two, that was pain at the site of instillation and conjunctival hyperemia. Blurred vision was present in less than 1% of the cases. And of course, cyclosporin A, 0.09% of the Sequa did not report any taste alterations, which is there with the liftigrast. So, what were the conclusions of the studies which were done with cyclosporin 0.09%? The conclusions were that from day one, no or mild instillation of site pain for more than 95% of patients. After just 14 days, it starts to act in the sense that it improves corneal staining. So its duration of action is only 2 weeks. At month 1, patients had reduction in total corneal staining and also symptoms which improved. Visual acuity also improved. Almost 2/3 of the patient were had clear corneas and tear production which nearly doubled. And at 1 year, more patients were still using this drug as compared to liftigrast and the commercially available cyclosporin 0.05%. And of course, the most common adverse events reported were pain and conjunctival hyperemia in these patients. So thank you very much for your kind attention. And if there are any questions, we can
Thank
take
you,
up
ma'am,
the
for that
questions.
enlightening talk. So this is your chance to catch hold of Dr. Namrata, ma'am. So she has vast experience in treating ocular surface disease, and she is an authority in any cornea topic or ocular surface for that matter. So this is a time for audience interaction. Any of your doubts can be cleared.
So I have a
Dr.
doubt.
Vijay.
I think let's clear that also. Where is Sun Verma? So what about the economics of Sequa vis-a-vis Restasis? Because I think people don't want to use Restasis because it is very expensive. I hope your drug is cheaper than Restasis.
Right.
Can the lights be on?
Lights.
The hall lights.
The cost of actually cyclosporine being marketed by Allergan, that is costing 25.55 for a box of 30 unims. Vis-a-vis Sequa, which has 30 unims, is costing 1722 rupees to your patients. So this is a 0.25 ml vial, which has got enough drops. Even if the patient is wasting it to use the unim, still it has got enough number of drops to take care of the dosage part. Almost 850 rupees economical per box of 30 unims as compared to Allergan's product.
Okay, I have another question for you. You have a cycloimmune which is 0.1%. So what do we do? Shall we tell all the patients stop this and start using Sequa?
So, ma'am, I have been only involved with promoting this product for last 16 years in my division only. So, this is one such product which will definitely, I would say, meets the unmet needs as you were mentioning about it. I'm not saying anything is bad, but only thing is that something better comes up in the market. As Madam was pointing out, the product cyclosporin, which is currently available in emulsion form, it is hydrophobic in nature and it takes good 3 months to reach the required concentration in tissues of cornea conjunctiva. That is how the delayed response of current cyclosporin is there. Now, since it is encapsulated with the hydrophilic outer layer, the penetration is far more superior, and within 14 days, you will see. I was reading through one of the promotional article given by Allergan that the concentration of drug reaching cornea tissues, it is 1440 nanogram per gram in cornea with their product, which against with Sequa, it is 4800 nanogram per gram. So you can imagine the concentration of the drug reaching cornea tissue so quickly and giving faster relief to your patients. Costs sometimes become imperative, but at the end of the day, what happens is the longevity of treatment with the conventional cyclosporin and the one which is available, since it gives a quick response, I think your patient's religiousness to continue with the medication and see the results quickly will be one of the best thing to happen for your patients. Choice is all yours. It is
Thank
a platter
you.
which is
Thank you.
available. But then I believe that the current, whatever new things are happening, it is for the betterment of patient. And hopefully, I think patients are going to benefit a lot. It's been almost 6 months of promotion, but then we have received a tremendous response. Even Madam Namrata also, I think she will vouch for it. She had been using since the launch of this product. And Dr. Anil sir also, I think I came almost 3 months back and met him. He has been also using
No,
it.
no, we are still trying it, Deepak. We've not
No, no,
watching for
I am.
it, but because we have a whole gamut of drugs, our this thing, and I can discuss it with the other panelists also. Our dilemmas are quite a lot. One, that the patients who are already on Restasis and are doing well will not change to Sequa because they are used to Restasis and they can afford it. One is
I,
this. Second is that, again, we know about restasis and we know about cyclosporin 0.05% that you can continue it for, say, at least 1 year. And if you want to stop, again, these are the things which we have to look even for the nanomicellar one. How long can you continue it? When should you stop? For what prolonged? How long do you, Dr. Anil? How long do you continue your cyclosporin for? I mean, we give it for say 1 year, and then when do you think you now need to stop it?
Yeah, it's difficult to say, ma'am. Like the Restasis, when they launched, they told that you can use it for 6 months to 1 year and try stopping it. But a lot of patients actually had recurrence of the symptoms once you stopped it. So a lot of them are on long-term therapy for for long periods.
Same for you, I think, Anita. Do you want?
Ma'am, I have not started using Sequa because the pharmacy where where I am working now
No, but
is not there is
cyclosporin in general.
Cyclosporin actually it is not a wonder drug and it takes its own time to act. So 1 year is the minimum time I give, and if the patient is
Madhu,
about
what about you? Minimum is 1 year, maximum
You,
Like,
till the time the.
I
So,
don't usually continue it on a long term. I use it for 3 months, ma'am. Give a break, use low dose steroids in between, and again start it.
Okay.
I don't.
So that is also a good model to, give breaks, to break that vicious cycle
Yeah,
which we
exactly.
were talking about, and then to
Yeah.
restart again.
Restart it, yeah.
I have patients who are almost on 5 years of cyclosporin, but the problem is the moment you withdraw, like Dr. Anil was saying, they are not happy with it and they want to, come back to it again. So I think with your product, these are the type of questions we will need to answer, which we've not answered with the existing products. And if that, is taken care of, then possibly. Of course, one big advantage is that it starts to act in less than 2 weeks, which is good, because then you don't have to put the patients on topical steroids for a prolonged period of time, which is 6 weeks.
The
So
other
you are
in-
shortening the topical steroid period by about 4 weeks.
The other indication where we started using it is in the post-refractives, high myopes, who are usually steroid responders. We are tapering them to loteprednol low strength along with this, and then slowly we are stopping loteprednol also and continuing on cyclispf, especially post-PRK.
Okay, yeah.
Post PRK
Post
patients.
PRK, high powers. High myopes usually become steroid responders.
Anybody has any question? Yes.
Good afternoon, ma'am. Ma'am, you have 5 layers of cornea. We already know that. There's something called Deuce layer, sixth layer. What is its composition? What's its main function?
Sixth layer of cornea. Is there any postgraduate here? That comes as a short note. The sixth of the layer of the cornea is Dua's layer, which
Deuce
is
layer,
Dua's layer, which is present just above the Descemet's membrane, and it's about 10 microns in thickness. And it's actually, I think, it's nothing but the condensation of collagen, which is present right above the Descemet's membrane.
So it is having collagen, not cells. It's having
No,
collagen.
no. It is having collagen. Anyone can frame a better answer than what I have framed. I'm sure Madhu can. Madhu. Any other question that anybody would want to ask?
Now, can I make a comment, ma'am? Like,
Yes.
see, this regarding other aqueous-based cyclosporin preparations, I don't know, I have my reservations about it. I've used multiple products and I have not seen the same response with the emulsion form, either Ristasis or the Secure product. So it is, I think, other one is much inferior, definitely.
Which one is inferior?
The aqueous-based
Aqueous
ones.
based is
compared to
much
emulsion.
inferior.
Compares, like we have a lot of products which are available which are aqueous based, which makes sense also because it is basically cyclosporin is lipid soluble. It does not penetrate the
Yeah.
cornea just like that.
I think you need to study comparing the two of them. Only thing is the sample size is going to be really huge,
Huge.
because you are comparing the same kind of product. And to be able to show a difference, you need in both the arms very huge number of cases.
Ma'am,
Like I said, we would need to study this. Of course, it's a good drug with a huge promise. Yes.
ma'am, you will be planning an in-house study, I think, no, in RP Center.
So
this
we
0.09.
have yesterday only submitted one on, I'll say in front of him, it doesn't matter, Restasis versus Sequa in dry eye, a randomized controlled study.
So any other indications you're planning, like higher risk grafts or pediatric grafts or?
No, as of now only
Dry
in dry
eye.
eye, but I'm sure there could be other indications. Just to complete the picture, topical cyclosporin can be used for so many things: to prevent graft rejection, to treat graft rejection, especially in steroid responders, ligneous conjunctivitis, dry eye, vernal keratoconjunctivitis,
SPK, no.
SPK,
Nummular keratitis.
nummular keratitis, adenoviral keratoconjunctivitis. I think it has a huge role to play, especially when you keep getting those nummular opacities again and again and again. So in that also, if you use topical steroids and topical cyclosporin, and then continue it, say, for some time, and then stop the steroids, and then continue the patient on topical cyclosporin, then the chances of recurrence are much less.
Thank you, ma'am.